Hello, this is Mrs. Alston, and today we will be covering lower gastrointestinal system patient preparation. So for the small bowel preparation, food and fluid may be withheld for 8 hours prior to the exam, and a low residual diet 48 hours prior is also good, but usually not mandatory, and the patient should generally be NPO after midnight. So an example of an adult cleansing routine would be to have a low residual diet for 1 to 3 days, nothing to eat after the evening meal or after midnight, take a cathartic between 2 and 4 p.m., and then bowel movements will begin usually within 2 to 6 hours after that cathartic is given. And then in the morning, a cleansing enema at least 1 hour before the exam. When performing a small bowel follow-through, typically the patient is going to be put in a prone position for their overhead images. There are some contraindications for putting a patient into the prone position, and that would be a known or suspected AAA or abdominal aortic aneurysm. If the patient has had recent abdominal surgery, if there's severe abdominal pain, or if the patient has a distended abdomen, that could also be an indication of an obstruction. For the small bowel, the first picture is typically done within 15 or 30 minutes after the patient has drank 16 ounces of barium sulfate or iodinated contrast. It is going to be centered approximately 2 inches above the iliac crest to ensure that we capture the entire stomach on that initial small bowel image. And then make sure that the images are timed and annotated to the correct time. So here's an example of a 2-hour small bowel. A would be the duodenum, B is going to be the large intestine starting to show up faintly, and then C is going to be the jejunum. D is the ileum, and we can tell that it's the large intestines because of the haustra or the Tenay coli fibers that are binding the pouches for the large intestine. Once the contrast has reached the ileocecal valve and you start to visualize the cecum, it is time for the radiologist to come into the room to perform his pictures. Now the main difference with the small bowel versus the upper GI and the lower GI is the radiologist comes in after the contrast has been given and it has reached a certain point, the ileocecal valve, whereas with the upper GI and the lower GI, the large intestines, the radiologist comes in first and administers the contrast. So here's just the picture of the ileocecal valve being attached to the cecum, and then you see the terminal ileum there and part of the ascending colon. So for the small bowel only series, if this is the only thing the patient's going to have done and you have not done the upper GI before, you're going to give the patient a total of 16 ounces of barium or iodinated contrast, and you're going to start timing after the patient has completed the first cup. So if they complete at 8 o'clock in the morning, then 8:15 is going to be your 15-minute, 8:30 will be your 30-minute. You're then going to annotate once you take the remaining pictures so that we know how much time has gone between the images. So we're going to take that first one, as I said earlier, about 2 inches above the iliac crest because we want to include the stomach. And then we're going to take images about every 30 minutes up to 2 hours. And then after 2 hours, films are typically taken every hour until barium reaches the ascending colon. Make sure, though, that every time you take an image, you have the radiologist take a look because that person is going to be the ultimate one that decides what interval you take your images. So this is just your plain radiograph, your regular KUB, and you can see that there are normal gas patterns within the large intestines. We usually don't see anything in the small intestines unless you have an obstruction. Here is the small bowel series at the 30-minute mark. So you see that the stomach is still clearly highlighted with the barium. Then you can see the C loop of the duodenum You see the jejunum, which is feathery in appearance, and then you see a little bit of the ileum coming in. Here is after 2 hours. You see the stomach still has some residual barium in it. The jejunum is lightly covered with barium, and then the majority of the barium has now entered the ileum, and you can see the ascending colon right next to the ileum. So now it is time to bring in the radiologist. Now you can also have an accelerated small bowel. So the accelerated small bowel, the purpose of that is to see the small bowel as quickly as possible. This isn't necessarily for the function, it's rather for the anatomy, because when you're looking at the function, you do not want to have anything that's going to assist with the movement or passage of the substances that the patient has eaten. You want to look at the actual transit time that it takes the bowel to process whatever the patient has had. But there are 3 methods if you're just looking at the anatomy and not the functionality used to accelerate the transit time. That would be 1, saline and barium mixed chilled. 2 would be barium and water mixture, which is going to make the barium even thinner than normal. And then 3 is going to be drugs used to increase the peristaltic activity within the small intestines. So we're going to move on and talk about the barium enema. So this is the look at the large intestines. The barium enema preparation is a little bit more involved than the upper GI and the small bowel. The goal is always going to be the same though. We want to have an empty large intestine because we don't want to miss anything abnormal going on. So an empty large intestine is imperative. And this is accomplished by some dietary restrictions, the use of a laxative, and cleansing enemas. If fecal material remains in the large intestines, it may be mistaken for a tumor. So the bowel prep is going to be to have the patient ensure that the intestines are emptied. And then if the patient is having multiple tests, we want to make sure that a sigmoidoscopy is done first and then the IVP. So the sigmoidoscopy has the same type of bowel prep as the BE does, as well as the IVU. You want to have the patient's intestines cleaned out. With the sigmoidoscopy, there's going to be a scope introduced into the rectum and then moving up into the sigmoid colon. And with an IVP or IVU, that's a study of the kidneys, and the kidneys lie directly behind the large intestines. So if we were trying to see the kidneys and there was fecal material in the bowel, that might obscure some of the kidney anatomy. Now, cathartics or purgative is a substance that produces frequent, soft, or liquid movements within the bowel. These substances can cause cramping, though, as well. The main cleansing routine used is called an irritant cathartic, and these substances increase peristalsis in the large intestine by irritating the sensory nerve endings in the intestinal mucosa. Irritant cathartics can help accelerate the large intestines from emptying out the fecal material. Examples of these irritant cathartics are castor oil, cascara saginata, and senna. Saline cathartics are a different type of a cathartic, and examples of these are magnesium citrate, effervescent sodium phosphate, magnesium sulfate, and milk of magnesia. The saline cathartics aren't quite as unpleasant as the irritant cathartics because they occur in a more natural way of a patient having bowel movements. So contraindications for using these cathartics would be if the patient is having gross bleeding, if they're having severe diarrhea, if there's an obstruction, or if there's an inflammatory lesion such as appendicitis, because this could help rupture that. For the room prep, we want to have the room and the table clean. The control panel will be set on fluoro. The fluoro time will be set to its maximum 5 minutes. You're going to have protective lead gloves and aprons. The fluoro tower will start horizontal typically. The footboard is going to be off if you're not planning on doing any upright imaging during the fluoro portion. The Bucky tray should be moved to the end of the table so the Bucky slot cover comes out. The foot switch should be pulled out and ready for use for the radiologist. The TV monitor should be pulled over so the radiologist can view the images. And you should have towels, a BE ring, which is something that would capture the barium if it happened to leak out. It's not going to go all over the table. It will stay contained within the BE ring. A bedpan, gowns, your biohazard trash box, your contrast that's prepared, the contrast bags and tubings that you need, lubricant, hemostats, and gloves. This slide is demonstrating what a closed system enema container would look like. This happens to be a single contrasted BE, and whenever you're hanging the BE bag, it should not exceed 24 inches from the tabletop. Gravity will help make the barium come out of the bag faster. So if the radiologist did want the contrast to go into the patient's intestines a little bit quicker, he could tell you to raise the height of the pole to allow for gravity to make the flow of the barium go a little bit faster. Here's some examples of enema tips. The types of enema tips are typically soft plastic disposable tips. They're the most commonly used. And for the use with hemorrhoids and anal strictures, this is the one that you would definitely want to use. The rectal retention catheter, also called the retention tip, is used with a patient who is having a relaxed sphincter or who can't hold the enema. So that is the one that's going to be in the middle. There is a balloon. If you look at the image on the right-hand side, you see the balloon is inflated. So once you have the tip inserted, there's an inflator cuff that attaches to a tubing attached to the tip. That cuff is squeezed, and then that puts air in the balloon, which helps to hold it in place. The tips have a thin rubber balloon that is inflated with air under fluoro and with the guidance of the radiologist. So the position that we place the patient in order to insert the tip is called the Sims position. The rectal insertion should be done once the radiologist is ready, and you should never force the tip. If there is a problem, have the radiologist perform under fluoro so not to damage rectal tissue. Using the Sims position, you're going to place the patient on their left side. The left leg is going to be extended with the right leg over the left leg, because this position helps to 1. Relax the abdominal muscles, 2. Decrease abdominal pressure, and then 3. The IV pole, as I said before, shouldn't be any higher than 24 inches or 60 centimeters above the level of the table. The bag can be raised if the radiologist wants the barium to go faster. You want to have the patient concentrate on their breathing because this helps to reduce spasms and it allows the abdominal muscles to relax. So for the tip insertion, you're going to insert the tip in a forward direction 1 to 1.5 inches aimed towards the umbilicus. The tip is directed superiorly and slightly anteriorly to follow the natural curve of the rectum. The insertion of the tip should not exceed 1 to 1.5 inches, and the tip can also be taped into place. Upon completion of tip insertion, the patient should be placed in a supine position. So the actual barium enema fluoroscopy procedure is to take general surveys of the pelvic area, check for proper tip placement, and then the radiologist will begin to flow the barium with the patient either on the left lateral side or supine position. The radiologist will then take the digital images that they are interested in seeing. During fluoro, the radiologist will have the patient get into various positions because this will allow to check for suspicious areas. It will aid in the advancement of the barium. And the areas that are most studied in positional changes are going to be the rectosigmoid area, the 2 flexures of the colon, and the cecal area. The radiologist will have the patient move into obliques and possibly the right lateral to assist the barium going to the cecum. You may see reflux through the ileocecal valve. Once the radiologist is complete, the technologist will then perform the overhead images that have been requested. Now there are types of barium. The additives improve the coating of the intestinal mucosa or assist the patient in evacuating the barium mixture once everything is done. The barium to water ratio is approximately 1 to 4 or 1 to 8 for single contrasted BEs. The barium can be mixed with saline or water, and water can be cold or warm. Cold would be about 40 to 45 degrees, and warm would be 85 to 90 degrees. If the water is too warm, it can injure the tissues, and it can be irritating and hard for the patient to retain. Cold barium mixture can be used as an anesthetic. The cold also stimulates the contractions of the sphincter muscle. We have pretty much gone away from the cold barium, and they like it to be room temperature. Your routine overheads for the single contrasted BE are going to be the AP and PA, the RPO, the LPO, the left lateral, the axial butterfly shot or rectosigmoid shot, and then your post-evac. Your single contrast is usually done anywhere from 110 to 120 kV in order to be able to penetrate the barium. For your double contrasted BE, the routine overheads are going to be an AP, a left lateral decube, a right lateral decube, a cross-table lateral rectum, a PA, and still your axial butterfly or rectosigmoid shot. You will note that your KVP does not have to be as high because your large intestines are not totally filled with the barium. The mucosal lining is just highlighted with it. There are two types of double contrast procedures. It needs to be free of fecal material, and then there's two ways that you can do either the double or the air contrast BE. The one is the two-stage procedure where the colon fills with the barium and then it is evacuated from the colon and air is then introduced. Or you could have the barium mixture and gas together filling the colon at the same time. Here's an example of a single contrasted barium enema, and you will note that the entire intestines are filled with contrast. Every person's intestinal anatomy is going to look a little different, and it's going to depend on their body habitus and where the soft tissues lie. Now note that this is an oblique because I can clearly see the Scotty dogs in the spine. So the patient is rotated into an RPO. Here's an example of a double contrasted BE, and you'll note that the barium is only going to be located in certain areas dependent on how the patient is positioned. Right now the barium is in the ascending and descending colons and the sigmoid colon, with the transverse colon being filled with air. So this is it for this portion of the large intestines patient preparation.